Good morning, this is Dr. Deepa from SRM Dental College, Ramapuram, Department of General Pathology.
So as we all know what edema is, to just brief it out, edema is nothing but the increased abnormal accumulation of fluid in the interstitial spaces as well as the serous cavities. So the next topic is pathogenesis of edema. So what exactly is this pathogenesis? Pathogenesis means the manner of development of a disease, or in other words, how exactly the disease progresses in the body. So now we are talking about edema. So pathogenesis of edema is the manner by which the abnormal fluid collects in the interstitial spaces as well as the serous cavities. These are the 6 mechanisms of pathogenesis of edema. These mechanisms can either operate singly or they can occur in combination to bring about the pathogenesis of edema. So as listed here, they are decreased plasma oncotic pressure, increased capillary hydrostatic pressure, lymphatic obstruction, tissue factors, increased capillary permeability, and sodium and water retention. So let us have a detailed picture of what these exactly are. Before understanding the pathogenesis of edema, let us briefly note down the normal fluid exchange that takes place in conditions where there is no edema and why there is no edema in normal conditions. So as you can see in the picture, the alveolar end as well as at the venular end, the hydrostatic pressure seems to be normal. The oncotic pressure, which allows the fluid to go out of the blood vessels, is also normal. And the tissue factor, that is the oncotic pressure and hydrostatic pressure in the interstitial space, is normal, and the lymphatic outflow is normal without any blockage. So whenever there is any excess fluid in the interstitial space, it is being removed away by the lymphatics, so that also is normal. Because of all these, there is no edema. Moving to the first mechanism, that is decreased plasma oncotic pressure. Here you can see that the oncotic pressure is reduced, wherein in the picture you can see there is a down arrow in the oncotic pressure within the blood vessels. So because of which there is reduction in inflow of fluid from the interstitial space into the blood vessels, but there is excess of fluid movement from the blood vessels into the interstitial spaces. Why this happens is because of reduction in plasma protein. So the major action of plasma protein is to draw fluid into the vessels normally. But whenever there is fall in total plasma protein, which in turn will result in reduction in plasma oncotic pressure, in such cases there is increase in outflow of fluid from the capillaries into the interstitial spaces, because of which there is increased outward movement of fluid from the capillary wall and decreased inward movement of fluid from the interstitial spaces. So example for this is edema in renal disease and ascites of liver disease, edema due to other causes which can lead to hyperproteinemia. The next mechanism is the increase in capillary pressure or increase in capillary hydrostatic pressure. So normally what this hydrostatic pressure does is it will tend to drive the fluid through the capillary wall into the interstitial spaces against the force of plasma oncotic pressure. So whenever there is increase in hydrostatic pressure, what happens is the plasma oncotic pressure results in minimal or no reabsorption of fluid, which in turn will lead to edema. Example of increase in hydrostatic pressure is edema of cardiac disease, which leads to postural edema. The next mechanism is the lymphatic outflow obstruction or the lymphatic obstruction. Generally, under normal circumstances, any excess fluid in the interstitial space is removed out through the lymphatics. But whenever there is any obstruction of the lymphatic outflow, the fluid that is accumulated in the interstitial space will be retained, leading to edema. Example of obstruction of lymphatic outflow is removal of axillary lymph node in radical mastectomy or inflammation of the lymphatics seen in filariasis. Mechanism is the tissue factors. So tissue factor is nothing but the tissue tension, that is the hydrostatic pressure of the interstitial space, and oncotic pressure of the interstitial space. Both together we call it as the tissue factor. That is the oncotic pressure and the tissue tension of the interstitial space together is called as a tissue factor. So in this mechanism, what happens is the tissue factor along with the other mechanism play a role in causation of edema. That is, there will be elevation of oncotic pressure of the interstitial fluid as well as lowering of the tissue tension. Example of this is loose subcutaneous tissue of eyelid and external genitalia. Increased capillary permeability. So the major reason for increase in capillary permeability is formation of gaps in the capillary endothelium. This usually occurs due to injury due to various poisons such as toxins and other products. So these products, they cause injury to the endothelial cell layer of the blood vessels, because of which gaps are formed, and through these gaps the plasma protein will escape to the interstitial space. So once they escape to the interstitial space, the oncotic pressure in the blood vessels will reduce. So once the oncotic pressure reduces, more and more fluid will escape from the blood vessel into the interstitial space, leading to edema. Next, moving on to sodium and water retention. In this we have three mechanisms of edema by which sodium and water is retained. One is intrinsic renal mechanism, extrarenal mechanism, and ADH mechanism. So in intrinsic renal mechanism, there is activated in response to sudden reduction in the effective arterial blood volume, which is nothing but hypovolemia. Whenever there is reduction in blood volume, this reduction or the hypovolemia will stimulate the baroreceptors, which is located in carotid sinus. This in turn will send sympathetic outflow through vasomotor center in the brain. Once there is renal ischemia, there will be reduction in glomerular filtration rate. This happens to retain the blood volume in body so that there is no much loss of urine output. So what happens here is, because of decreased excretion of sodium in urine, there will be retention of sodium. Next, moving on to extrarenal mechanism. In extrarenal mechanism, there is secretion of aldosterone by renin-angiotensin-aldosterone system. This in turn will release renin when it is stimulated because of low sodium concentration. This renin will in turn convert angiotensinogen to angiotensin 1. On stimulation, this angiotensin 1 will be converted into angiotensin 2 by means of angiotensin converting enzyme, that is ACE. This in turn will stimulate the adrenal cortex to secrete aldosterone hormone. This aldosterone is the main reason to increase sodium in renal tubules. Next is the third one, that is the antidiuretic hormone. Antidiuretic hormone mechanism, what happens here is there will be retention of water following retention of sodium because of the influence of antidiuretic hormone. So the release of this hormone is stimulated whenever there is increase in sodium. When there is increase in sodium, and there will be also hypovolemia. So both of this together will lead to large amount of antidiuretic hormone, which in turn will produce highly concentrated urine. So example of this is edema of cardiac disease. With this, we end the session of pathogenesis of edema. So we came across the 6 mechanisms of edema. Meet you in the next session. Thank you.